Okay, hi, this is Dr. Kirsty with Rewylding the Feminine, interviews with the women I love and the work that they do to serve in the healing arts. And today I'm here with Dr. LCheek, a doctor of physical therapy. She's now at Holy Cross Hospital here in Taos, and so I'm really excited to introduce you to her. And she's a pelvic floor specialist, and most of you guys who have worked with me over the years know that I love the pelvic floor or the pelvic diaphragm or the pelvis or anything around the pelvis. I get really excited about. So I'm hoping that we can dive deep into the pelvis and talk about issues, especially with women and giving birth and healing, and even maybe a little bit about perimenopause and menopause as well, if you're into it, because as I'm aging and going through perimenopause and getting closer to menopause, I'm also seeing kind of this other side of it. Of course, I gave birth to my daughter 20 years ago, had that experience and what that was like. And that sent me down a pathway of wanting to understand the pelvis, and also just within my structural integration practice and body work practice, how to help support women to reclaim their pelvis is a big part of my work too, and the energy around the chakra system and the tribal system and family and all the energetics that are around the pelvis as well. So there's a lot within this I think we can play with. But maybe you can talk a little bit about how you got thrown into being a pelvic floor specialist, because I don't think that's not normal. I mean,
No,
not in the field of physical therapy, even.
yeah, it's not the typical path that most physical therapists take. And well, I didn't really take the typical path to become a physical therapist. So, it's just kind of fitting in my own journey. But, well, I just first want to say thank you so much for having me. And I'm really so glad to have connected with you here in Taos, because it's really, I'm the only pelvic specialist here at Holy Cross Hospital. And I came from a big private specialty practice up in Denver, Colorado, where I was surrounded by pelvic floor nerds all the time. And so
Yeah.
I've been feeling a little sad that I don't have anybody to geek out with on the
Anytime
Yep.
when this whole COVID thing's over again, we can hang out after work. No, I mean, it is a challenge here because we're so rural, and we don't having specialty practices. And most people have more of a general orientation in their practice, and specializing in something is rare here. You have to go to Santa Fe or Albuquerque, and even there, I think there's only
just
maybe one or two maybe in Santa Fe, and one or two really in Albuquerque. I mean, in New Mexico as a whole, we're really lacking people who understand how to do pelvic work.
Absolutely, I agree.
And,
well, that's a big part of the reason I wanted to come back here to New Mexico, because, well, number one, it's my home. I'm from Santa Fe, and so I always knew that I wanted to come back here. But to be able to offer this to the community that I really care for is a really special opportunity. So, in answer to your question about how I got into pelvic floor PT, so how I got into PT in general, I worked as a pastry chef prior to getting into the medical world. And once that kind of fell through and I decided I wasn't really going to go that route, I got very much into yoga, and in particular adaptive and therapeutic yoga. And I was really inspired by a teacher named Matthew Sanford. I don't know if you've heard of him.
No, I haven't, but I'm curious. Yeah.
He's paralyzed from the chest down. He was in a horrific car accident when he was a teenager, and he lost a couple of family members in that accident and lost all movement and sensation from the chest down. And he went through this journey of, first trying to disconnect with the area of his body that was injured, and then to try to overcompensate, by going like the wheelchair athletic route. And then when he found yoga, he was able to really restore a level of energetic sensation and movement in an area that he wasn't, by all accounts, should not be able to have any sensation or any movement. And so I came into contact with him in Denver in around around like 2010-ish, and was so inspired by what he was doing, and, using movement and energetic sensation, as a way to connect with our bodies and really as medicine. And so that's how I became interested. And, with lots of contemplation, trying to figure out, how do you make a job out of that, I found physical therapy that seemed to be the best fit for me. And because of my work with Matthew Sanford, I became very interested in neurologic PT and patients with spinal cord injuries and stroke and neurologic injuries. And that's kind of the route I thought I was going to go. And I did some of that as a student, but then I heard about this thing called pelvic physical therapy. And I was like, wait a minute, you're kidding, right? Like there aren't PTs that do that for real. But the more and more I learned about it, I realized a few things. Number one, I was fascinated by it. The anatomy, the physiology, and just the interpersonal element of treating issues in this area was just so interesting and so appealing to me. And so I realized that I loved it. I realized that I was a good fit for it. You have to have a certain kind of personality to be in this field. You have to be very open and, very okay with talking about very taboo subjects. And, my whole life I've kind of had this personality where upon meeting me, people just often spill their guts to me unsolicited. And so it's a good quality in this field. And then, but the most important was that I realized there was such a need for it. There are so many people suffering with bladder issues, bowel issues, pelvic pain, people of all genders, all ages. And there are so few people that are willing to get into this area and really, dive deeply into these issues with patients. Even healthcare professionals are very reticent to have conversations surrounding sexual health or digestive health, or really even to talk about trauma with their patients. And
absolutely,
and that's a huge part of what we deal with. So when I got into field, became licensed and graduated, that's the direction that I went in, and have never looked back. So it's kind of interesting being in the rural setting, because you do have to be somewhat of a generalist, as you mentioned, but the more and more you get into that general practice, the more you realize that so much comes from the abdomen and from the pelvis. So even these issues that don't seem related, so many of them have their root kind of deep in the midline of the body. So it's been a really good experience to branch out of it.
Yeah, well, and I think there's so much shame around the pelvis that's why not a lot of people have a lot of shame, at least, and they don't want to open up in the vulnerability to really talk about what's going on for them. And a lot of alternative practitioners who focus on this are very open about talking about these issues and find a way, but also sometimes in traditional allopathic, we don't always have that bridge. And that's what I love about you, is that you seem to have bridged the traditional healing arts with the allopathic in your approach and how you're working with your patients. So
it's fun. I kind of see myself as a bit of an infiltrator in the allopathic world, because I do get to, dabble in all these various modalities while still, being firmly rooted in evidence-based practice. And it's fun. It's really fun. And to be able to reach people who, in the traditional medical model have been failed, honestly, because I deal with a lot of folks with chronic conditions and conditions that aren't well understood, like endometriosis, fibromyalgia, chronic fatigue syndrome, a lot of these conditions where Western medicine is really only going to take you so far in that, they can, something very sinister can be ruled out. But as far as healing and managing, there's, that's where we're kind of lacking. And it's very fulfilling to be able to work with these patients and let them know that, I can't fix anybody. That's not I'm not magic. But my role in this field often isn't to fix somebody. It's to be with people and to be present for what they're going through, and really be supportive in people finding, somewhat of a new normal in their journey, and to learn how to integrate that and to be happy with that. And so
I
that's
really like
really
that.
helpful. Mm-hmm.
Yeah, I wanted, because those are terms I use too. It's like new normal, and I can't fix you, but I'm a facilitator. I can help you. We can explore different things and ways of support, different resources, different pathways to help support people. Because I did my doctorate in fibromyalgia, and I really learned a lot about how trauma influences especially the ACE, the childhood trauma inhibitors, really influence these chronic conditions, and it takes a different attention by a practitioner to give time for that to come forth, right, in the treatment. And so that's something that I also have noticed. But let's get back to the pelvis. So I watched your lecture yesterday. So anybody who's interested, Holy Cross Hospital page, it's on the live feed, but it's also recorded. Introduction to the pelvis was great. And you talked about the 4 S's. So I thought maybe we could start there.
Sure.
And I also, you kind of blew past the 3 layers of the pelvic floor, but I want to talk about the 3 layers of the pelvic floor and the pelvic floor diaphragm. Some people don't like the term pelvic floor. I don't care. I like diaphragm and floor. It is a diaphragm. And I also want to unpack, you talked about, I may be saying this wrong, the hanging quality, the spine, right, piece. And I think in structural integration, we look at it in a different way. So later on, we can maybe debate that a little bit.
Yeah.
That was kind of what I was thinking.
I'm into it.
Okay, but let's start with the 4 S's. I think that if you want to talk about those, and as we are unpacking the pelvic diaphragm.
So, well, actually, there's 5 S's really, but one of them I don't go into in a lot of detail because it doesn't make sense to a lot of people. So I'll tack it on to the end of this. So first S is going to be sphincteric function. So the pelvic floor lives at the bottom of the bones of the pelvis and surrounds the opening of the urethra, in women, the vaginal canal, and then the rectum, the anus. And so a sphincter is just a circular muscle that surrounds an opening, and it controls what goes in and what goes out. And so the sphincteric function of the pelvic floor has a lot to do with continence of bladder, continence of bowel movement, and also with communication with the bladder, and facilitating the reflex that happens when we have to go to the bathroom. It's this really complex cascade of events that happens as our bladder fills. Nerve endings in the detrusor muscle, the muscle around the bladder, are constantly in communication with the sphincteric muscles of the pelvic floor. And they're looking for feedback from those muscles to know, is it time for us to squeeze and empty the bladder, or is it time for us to relax and let the bladder fill? And so when we sit down on the toilet, our sensory cortex in our brain gets that information that, okay, now is the right time. And then the sphincteric muscles are going to relax somewhat voluntarily, somewhat involuntarily, and that's going to give feedback to the detrusor muscle via a really complex cascade of events in the brainstem and the spinal cord, and in the bladder itself, that allow us to eliminate urine. And then the defecation reflex for bowel movements works in a similar manner. So it gives this kind of feedback loop to our digestive and our urinary systems about when it's time to void. Second S is going to be stabilization. So we talked about the pelvic floor, the pelvic core yesterday. And when we're talking about the core and pelvic PT, we're talking about 4 muscles that provide stability to the spine, to the pelvis, and to the organs of the abdomen. So those 4 muscles are going to be the diaphragm up top, pelvic floor on the bottom, transverse abdominis around the midsection of the trunk like a corset, and then the multifidi going up the spine in the back. And if the transverse abdominis is our corset, then the multifidi are going to be the strings to the corset. They're going to tighten that thoracolumbar fascia and draw that corset inward to regulate pressure in the abdomen. Sexual function is another really important role of the pelvic floor muscles. And we talk about the 3 layers I'll get into specifics about that. But really their role in both females and in males is to facilitate blood flow into the sexual organs, to contract and keep that blood flow from leaving the sexual organs, and then rhythmic contraction during arousal and orgasm. And then when we talk about reproduction, there's a muscle surrounding the opening to the vagina that really has to spread and open in order to allow that little head and shoulders to pass through what is normally a very small opening.
Right.
So that's
so little,
yep.
That's a little head.
Yeah, because it wasn't little. It shouldn't feel little anyway.
No.
Yep. So let's see. We've got stability, sphincteric, sexual. Oh, and then support. So we've got the organs of the pelvis, the bladder, the uterus, and the descending colon and rectum. And they're held up. They have a lot of different, all organs in the abdominal and pelvic cavity have a lot of different mechanisms which hold them up. All those organs are really big and heavy, and they have a really complex support system. So number one is going to be negative pressure from the thoracic cavity, which allows air to flow inwards from the outside world when we breathe, and that negative pressure holds up organs in the top part of the abdominal cavity, the liver, the stomach, the spleen, the pancreas. Those are all held up by that negative pressure. There's also a system of ligaments that connects the organs to one another and to the walls of the abdomen, and then surface tension helps to support those that kind of big mass of organs as well. Excuse me. So as we go down in the abdominal cavity and into the pelvis, we've got negative pressure up top and positive pressure in the bottom part. So once we get down to the pelvis, we've got quite a bit of pressure pushing down on these organs. Now they are also supported by ligaments, but they need that extra lift from the pelvic floor to counteract that pressure. Now when we're up and moving and using our muscles during our day-to-day activity, there is pressure that is created in our abdomen, and the pelvic floor and the core muscles need to regulate that pressure inward in order to provide stability. Now if there's an issue with core weakness or pelvic floor dysfunction, that pressure gets displaced downwards, and that's where we run into problems with urinary incontinence, bowel incontinence, pelvic organ prolapse. Those are all just problems with pressure regulation in the abdomen. And then the fifth, go ahead.
Go ahead. I wanted to unpack something there with support though, because one of the things I learned over the years of teaching yoga and the whole kind of thing around the mula bandha, right? Which is like creating that engagement, and then you ended up with a lot of yogis with hypertonicity. Right, and they create a shortening between the ischotuberosities and the sit bone, or between the pubic bone and the anus, and so they actually shorten what we call the diamond. Right? And they don't have that response pattern anymore. So we have that hypotonicity, right? Where is that one thing that you're lack of support, but then we have like Pilates and yogis who have like
have been holding on for dear life. And people, and I think it's a cultural epidemic, really. We hold so much stress in our gluteal area, in our adductors, in our pelvic floor. And so I would say the vast majority of people that have support issues really do tend to be more hypertonic. I rarely see anybody who's just completely like flaccid through the pelvic floor. That's usually going to be like my really elderly patients who are really severely deconditioned just in general. But yeah, most people who have support issues, there is muscle strength, but then there's also length tension in between in the muscles, and the muscles have to be at an ideal length in order to create sufficient tension to do their job. And when they're already in that shortened state, we call that active insufficiency. They're already shortened, and so they can't generate force in a productive way. So that's huge, and it's not really well understood either, which is where a lot of that mythology surrounding the Kegel comes about, and that most people think they just need to strengthen when, as you mentioned, especially with people who do tend to have very strong cores do tend to be really hypertonic. So
yeah, well, and I unpack the Kegel too in my book that I wrote back in 2013, which I throw the whole book out, but it was on myofascial yoga, and I really talked about hypertonicity and and that the whole thing around that. And I found it interesting because at that time it was really hard to access information around this. A lot of people really didn't want to talk about it. So I mean, it took some serious digging around to start to pull that together. But I think I may have actually gleaned that through a physical therapist at first, back then. Yeah. So what's the fifth S? Okay, now I'm curious.
The sump pump. So that has to do with the lymphatics.
Okay, yeah.
Yeah, so we know that I'm also a lymphedema therapist. That's my other specialty is chronic swelling and diseases of the lymphatic system. And so we know that the lower part of the body, the legs, the inguinal region, the genitals are drained by lymphatics in the groin and deep in the pelvis. And so it's thought that rhythmic contraction in the pelvic floor while we're breathing actually helps facilitate drainage from the lower half of the body. So that's the fifth S. It's not when I'm talking to the general public, it's not one that I usually bring up just because it raises a whole lot of other questions. And when I want to focus on the pelvic floor rather than the lymphatics, it's more for brevity's sake. But as a lymphatic therapist, I think that function is also really interesting.
Well, absolutely. I mean, and anybody who's worked with cancer and metastatic breast cancer and how that impacts the whole system, it's really important to have people who've been trained in lymphedema and help support that system. Yeah. So, I mean, it's great. I'm so glad we have you in town. And because I was excited, like when we first connected, I was like, oh, yay. We have somebody to refer people to as well. I don't take medical insurance, so not everybody can access me in my work, and so it's really important that we have people who can, have an access and get a script. Do people have to get a script to come see you from their primary care, or can they call and just say, I need this work?
So I'm learning a lot about the insurance system here in New Mexico. By and large, most insurances here are going to require a referral from a physician or a non-physician provider, like a nurse practitioner, nurse midwife. There's a list. It was different in Colorado where I was practicing, where we did have a true direct access model. Anyone could walk in off the street. Technically you can here too, but insurance is a little weird about it here. So just to be safe, we'll say yes, you do need to be referred. But typically most physicians are very, very no one's going to fight you on it if you call and ask your physician for a referral. They're usually very, very apt to send people out for this kind of stuff. So.
Yeah. Okay, cool. So is there, I think this is interesting too, because I just know a lot of people from the structural integration, the Rolfing world, we have a lot of debates. And I think one of the things that we know is that we don't really get taught anatomy when we go to school. Like I'm talking about not even college, like high school or even younger. We really don't get taught what all this stuff is. Like Susan Weed has a book and she calls it Down There. And the first time I taught a class on the pelvis to yoga teachers, they were like they were quoting her, well, down there. And I'm like, well, what's down there? Oh, you mean the pelvic diaphragm? Like, I'm like, you mean these muscles? Let's talk about what it really is. Let's not make a myth of it as it being like down there. Like, let's really talk about the structures and get to know it. And a lot of the work that I'll do is I'll have people I'll show them their pubic ramus and I'll have them touch their pubic ramus. And we talk about how that needs to have an anterior load. And we really talk about the rocking of the pelvis. And, I go through how to sit with people to get them, their pelvis is higher than the knees. And we do all kinds of things in movements to free up and activate. But that's one thing that's one of my biases is that I don't like making it separate. We should embody our pelvis and know the bits and the parts that make it up. And so that's one of my things. I don't know.
Yeah, I'm with you.
Yeah, because those are all such important functions, right? I mean, going to the bathroom, sexual
Mm-hmm.
relationship is such an important thing. The sub pump piece, the stabilization,
Mm-hmm.
all of those things are so important. And that support piece, to me, I mean, it's such a metaphor.
Mm-hmm.
Like if you feel like you lack support in your life, you
Mm-hmm.
probably lack support in your pelvis too.
Probably. I mean, it's the base of everything. It's the root of everything. So
Yeah.
I think that's a really important way to look at it. And it's interesting because in physical therapy, I mean, we are so well educated in anatomy. I would say, I had friends who went to medical school, and our anatomy training in PT was far beyond, especially musculoskeletal anatomy, was far beyond what most physicians, save orthopedic surgeons, are going to have in school. And we spent so much time and so much energy learning about anatomy, and we didn't even cover the pelvic floor as a topic. It was a special interest section during our cadaver dissections. And I was just shocked at that. I was completely shocked. And we learned, and then, going into, technical pelvic physical therapy, in my entire doctorate program, we got a 1-hour lecture and a 2-hour lab on pelvic floor in 3 years. And it was just enough information to scare most people away from it forever, and then to leave the rest of us who really did want to learn about it and were curious with way more questions than answers. So even, I don't know, there are some schools in which pelvic education and gender health issues are standard, but for a lot of schools, mine included, it's more of like a niche thing, and we didn't even have electives on it or anything. So I had to seek it out on my own, which was kind of sad.
Yeah, well, I mean, I think that when I did pre-med A&P, the myoskeletal system, we covered it in 1 week.
Yeah,
And
that's the one we got.
and then licensed massage therapy was really where I got more the myoskeletal system, but it's really just been my ongoing study, continuing education and studying under a lot of other teachers, and really dissection.
Yeah.
Dissection labs up in Colorado Springs is where we've been gifted such amazing teachers, which is the donor body is what we call the teacher. And that has actually taught me more about the viscera, the pelvic floor, and, going in multiple times to really take a look at that and to see the variety. Like for interest of some people, if they're watching, you have your uterus taken out, there's going to be a prolapse in your colon. It's going to infill that space. And it doesn't just stay empty. And I think a lot of people don't realize there's an impact, because it used to be that hysterectomies of, taking the uterus out was really common. Like, oh, well, you don't need that anymore because you're an old lady.
Yeah.
So, I mean, it's just, it's amazing to me but, we, just doing the dissection trainings over and over again, we've had a lot of opportunity to get in there and look at what has happened to the female anatomy and the impact that's had. And also what, how do I put this, like torsion in the system alignment stuff, how that really can come up and affect pelvic alignment, sacral alignment, and then affect the organ placement. So
yeah, and it's such a shame because the anatomy itself is so fascinating. It's such a glorious system. I'm constantly amazed by, the anatomy itself, like you said, the variation person to person, the way bodies compensate for various demands on the body and traumas to the body. And, it's such a beautiful system, and it's a shame that it's swept under the rug in education so much, because it's awesome. I love it.
Well, maybe we'll keep working on bringing it into the forefront. I mean, we really try in our medical massage program at UNM Taos to really spend some time around the pelvic floor and to talk about the importance, obviously, because I have that bias.
Yep.
No, let's talk about it. Let's look at it, and let's, learn some of the structures that are involved in that. So let's talk about the pelvic floor diaphragm. You talked about the 3 layers. You kind of mentioned it. It was kind of, to me, that kind of stuff is a tease when we don't get into like the details.
Yep. So we can get into them.
Yeah. So let's just talk about that, because we had the levator ani, right? And the pubic
Mhm.
coccygeus. I don't know what else you were thinking in there, but let's talk about what.
Yeah, so, and unfortunately, I don't have a great visual model here, but I can try to talk you through it a little bit.
That's
So,
fine. People can Google it.
yeah, right. So the first layer of musculature is what we call the urogenital triangle. So if we think about our pelvis and our pubic bone, that's going to be the triangle underneath the pubic arch there, and then it's going to come in the middle to the perineum. Now the perineum is the space between the vaginal opening and the anus, and that's where all the muscles of the pelvic floor form this kind of fibromuscular junction in the middle there. And then posteriorly in the back, we've got the anorectal triangle, and that's going to be those perineal muscles, and then the external anal sphincter, which is the conscious control of our bowel movements. So those urogenital triangle muscles, those are the ones we talked about with regards to sexual functioning. And there's one in particular, the top part of the triangle, the ischiocavernosus, that in men and women actually serves the exact same function, which is when blood rushes into the genitals during sexual activity, it contracts and blocks the outflow of blood. And it does that in women and in men in the same way, which I find so fascinating.
Yeah.
Histologically, from a tissue standpoint, the tissues really aren't that different. It just looks different from the outside. So, a really fascinating function. And then if we go a little bit deeper, we've got the second layer musculature. These are going to be the muscles that surround the urethra and form that sphincteric function. So there's a number of muscles in there: the compressor urethrae, the sphincter urethrovaginalis, the deep transverse perineal. And those, they used to call it the deep perineal pouch. I think the terminology changes with every time I start to restudy it. But essentially, I think of those as the urinary sphincter muscles.
Mm-hmm.
Sorry, that's our intercom here. So those are the muscles that I think of as having the sphincteric function and that feedback loop function with the detrusor muscle in the bladder. And then when we get deeper into the levator ani, that's that big diaphragm-like structure that forms that sling in the bottom of the pelvis and closes off the bottom of the pelvic outlet. So there's three muscles that are part of that group. So puborectalis is going to form a little lasso from the pubic bone around the rectum, and it actually keeps the rectum at an angle, and that plays a really important role in continence of our bowel movements. So when we sit down and we get the signal that it's time to have a bowel movement, puborectalis relaxes and the rectum becomes straight. And that's how bowel movements are able to pass through. So when we get into situations of hypertonicity, like you were talking about, that's where we run into outlet dysfunction, constipation, that puborectalis can't relax, and so the rectum isn't ever able to easily pass fecal matter through. So if you've ever heard of the squatty potty, when sitting with that good bowel posture with your knees above your hips, that actually slackens the puborectalis muscle, and that's mechanism of making it easier to poop. So then going outward, the pubococcygeus, kind of figure 8 from the pubic bone, cross the midsection, and then back onto the ligament connecting to the coccyx, and that's a support muscle. And then lateral to the side of that is going to be the iliococcygeus, and that's another big broad support muscle. And so the iliococcygeus, it attaches in the back to the coccyx through that ligament, the anococcygeal ligament, and then on the outside it actually attaches to a muscle called the obturator internus, which is a hip rotator muscle. And that muscle forms the connection of the levator ani to the bones of the pelvis. And so even though it's not technically part of the levator ani, it's a really important part of the support system there. The problem with that muscle is that, so there's fast twitch muscles and slow twitch muscles. A fast twitch muscle is a mover. It's meant to generate power very quickly, and it fatigues really quickly too. And then the slow twitch muscle fibers, the pelvic floor, the levator ani is going to be about 60% slow twitch fibers. Those are muscles that are designed to be on for long periods at low levels. and those are our support and stability muscles. So if there's some kind of dysfunction in the pelvic floor and those muscles aren't performing their function correctly, the obturator internus likes to try to step in and say, hey, I can do this job. I'm part of the pelvic floor. The problem is it's not. It's a fast twitch mover muscle. And so it gets fatigued really quickly, gets overworked, and can be the source of a lot of pelvic pain and pelvic dysfunction. And so it's an extremely important muscle when we're talking about pelvic pain disorders. And then other muscles in that pelvic bowl that are important, the coccygeus goes from the outer part of, the back part of the pelvis, the ischial spine, to the tailbone. If you had a tail, that would be the muscle that you squeeze to wag it. And it's not technically part of the pelvic floor, but does help close off that the bottom of the pelvic outlet. And then the piriformis coming from the sacrum, which is also a deep hip rotator muscle, shares fascial connections with all of those muscles in there. So there's a lot going on in there.
There is. And it's good to get like the review and because I think about how much, just even my own body, because as a cyclist and some of my trauma history in my body and the injuries, obturator internus will step in to try to navigate that. And, it's really kind of an overuse. And I have to do, fortunately, I know how to do muscle energy techniques and myofascial release. So I'll do a lot of stuff on myself to like say, hey, that's not your job. Let the job go back to where it belongs. I have to have these kooky conversations to like get things back into balance. But I think it's really important. One thing I didn't hear you mention was the sacral tuberous ligament, which I'm a huge fan of, because you know how that stabilizes the posterior sacrum, and a lot of people carry a lot of tension there as well.
And the sacrotuberous and sacrospinous ligaments, they are really closely related to the coccygeus and the piriformis muscles, and also to the path of the pudendal nerve, which is the main sensory nerve that innervates the clitoris, the perineum, and the rectum. And that exits in the sacrum at around the second, third, and fourth levels, and kind of dips and dives through and around those ligaments, and then pierces the obturator internus, then exits around the sits bones. And so when we're talking about pelvic pain, those ligaments become extremely important, because that nerve goes through all these really irritable structures and all these structures where we tend to hold a lot of tension and a lot of overuse. And it's a nerve like any other. I call it the funny bone of the pelvis, because it's true damage to it is fairly rare, but that nerve can get irritated so easily through, imbalance, overuse, tension, things like that. So the ligamentous system is super important.
Yeah. Well, and I call that the pudendal sandwich a little bit, when the spinous ligament and the sacral tuberous ligament kind of go, and almost like they're just like, and then the pudendal doesn't, and then people are wondering why they have the pelvic floor pain in the front, but they don't realize it's coming from the posterior or the back side. So it's very interesting. That's awesome. I was going to throw one other thing, just because when I was in the lab last time, we spent a little bit of extra time exploring the clitoris and the crux and the arms of that, and how it actually has a direct innervation or connection with the gracilis muscle, which is one of the adductor muscles. So there's actually like a fascial wrap that's contiguous, if you will, with the gracilis. And that was also very interesting and kind of an aha moment for me in referral patterns of the adductors, and that can go directly into the pelvic floor. And then not so much to think about it just as an erogenous zone, but with regards to pain and a sense of where we are in our bodies when we have really tight adductors, for example, which I'm so guilty of.
Most people are.
Yeah. And how to release, like a tight adductor, and how that literally pulls and creates havoc, if you will, through our support mechanism.
Yeah, the adductor and the abdominal fascial connections with the pelvic floor are so important and so often overlooked. from a myofascial trigger point standpoint, which is a lot of my education, the adductors, the gracilis, adductor magnus, adductor longus, tend to, they're trigger points that tend to pop up, pretty far down, kind of around the knee, that really do light up deep within the pelvic floor and can be the source of a lot of that very diffuse pain really deep in the pelvic bowl, what a lot of people will interpret as bladder pain or ovary pain is often coming from the adductors, or is at least very much influenced by what's going on in the adductors. So I find that connection really fascinating.
Yeah.
So I do want to see this information you had about the gracilis clitoral connection, because that's amazing. I love that.
Yeah. Well, I mean, it was very interesting to us, and we were, because when you're in the lab, you get to choose what you see, and that's the thing about studying gross anatomy, is you choose how you angle your knife, whether or not, and that every time you make a cut in the lab, it's a very powerful choice, because you can do gross anatomy like to make it look like the picture books in anatomy, or you can choose to try to see something different. And changing the orientation of the knife and how you look at it changes what you see. And then the teacher really reveals something, and something else can come forward. And because my background is really in studying the fascia and the connective tissue, I'm always interested in these layers. Where's the perifascia? What's in this layer? What's between this and this? I'm always also very interested in the circulatory system and how it maps up, like femoral nerve and artery, and then adductor hiatus, and where's the tensional aspects in that compartment. That's something that's always been very interesting for me in the lab. And, I have my own biases around that, because I have some pretty big soft tissue injuries around my femoral nerve, and like scar tissue, like glomming, if you will, and grabbing the femoral artery and nerve. So it's like, how do you heal that? So it's purely selfish on my part, but it's proven to be very helpful in working on clients, though, that are having that kind of pain in the inner thighs. And I work on enough people who are athletes that do have a lot of hypertonicity in the adductors, in the pelvic floor, and learning people to like soften, let go of their pelvis, like putting them onto yoga blocks, sitting in Virasana, and asking them to let go of the pelvic sling for a little while, learning to relax things down as opposed to always lifting up. That makes sense. So it's really kind of a reverse way of working with people in some ways, I found. People think we always have to be like up, 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 but what about letting gravity support you?
Which we're not super good at, are we? Especially as women. I mean, we have so much grief surrounding our abdomen and around our pelvis, and I'm having to really work on that myself. I'm 8 months postpartum, and really had a lot of issue in returning to movement and doing my own rehabilitation. And, that's led to some kind of, the baby left some baggage, let's be real. And I have found myself just walking around with my stomach just gripping on for dear life, just because I don't like how it looks when I'm doing what I know I need to be doing in order to, facilitate my diaphragm and the motion of my pelvic floor during breathing. These are things I know intellectually that I need to do, but it's just been such a hard pattern for me to break of walking around with my abdomen just on fire all the time. And so that's something that I'm learning a lot about right now too.
Yeah, well, I think it's helpful to look at some of the old images, like sculptures of like Venus, and all of them have these beautiful bellies, and like the feminine form really is like that level of dynamic quality. And it's I think in our culture we just haven't learned to embrace the feminine form anymore. It's like disappeared somehow in the Middle Ages. It was a long time ago, right? Or the Renaissance, that a more shapely, curvy form was more sexy. And somehow that's been put like on the back shelf, and we have this really kind of almost gender neutral look that has been promoted, as
Exactly.
opposed to something that's more curvy and natural for a lot of the feminine form. And I mean, be honest, I don't think my hips have ever gone back since I gave birth to my daughter. And I don't think I've ever 100% gotten rid of the little bit of the pooch that's been left behind, but I want to honor it because it grew this like beautiful child.
Mm-hmm.
You know, I mean, it's like the remnants of, and the scar and the growth, you know, some people get this, the, what do you call that? The stretch marks.
Mm-hmm.
I mean, it should be just beautiful, right? We should just honor that as the step of being the mother.
Mm-hmm.
Stepping
Oh,
into that
couldn't
role.
agree more. Intellectually, I'm trying to get
Right.
trying to
Well,
get
I'm
through
giving you
myself.
encouragement.
Thank you.
No,
Thank you. It's a journey, isn't it?
well, and you know, I think most women really do struggle with that and they work really hard, but you know, our hormones change, the elastin changes in our tissues, and we can do a lot of things to help support us, but it's a new normal. Once you're a mom, there's a new normal. And if you're breastfeeding, all these things like affect our physicality. And
Mm-hmm.
then we're also aging as we
Mm-hmm.
become moms.
Mm-hmm.
And, you know, what our body wants to be is different.
Mm-hmm. And it's fascinating to watch. It really is. You know, you think you have such a connection with your body, and then it starts doing these things and that you don't even recognize. That it's hard to even identify as your own body, and it's you kind of have to be the observer almost, rather than trying to fight against it, or you know internalize it. It's for me, it's just been helpful to step back and kind of watch it from the outside in and think, wow, this is fascinating. This is unbelievable what intelligence the body has. And even though I don't fully understand it yet, it's you need to watch it, and you need to just be present for it. And it's so
Right.
interesting.
Well, and I think it's so important as women that we support each other in that
Mhm.
process and that we
Mhm.
offer a mirror and support in it. Because there's a lot of expectations that are really unrealistic for moms in our
Mhm.
culture,
Mhm.
especially, and I found it really hard to, like going back to work and being a mom with an infant and all these, the level of stress
Mhm.
that just creates on the system, like your adrenals. It's
Mhm.
really hard. I mean, it's hard to leave a baby in daycare. I mean, come on, we all know that have gone
Mhm.
through that. It's like, oh my God, this is like, I don't want to leave my baby behind. And but
Mhm.
you know, and the choices that we have to make are just incredibly hard.
Mhm. Yes, I couldn't agree more. It's
Yeah.
unfortunate.
Yeah. I mean, and you know, I think that also impacts the health of our pelvic floor and our
Mhm.
body, because there's a sense of grief, if you will,
Mhm.
because we've
And
lost. Yeah.
and that expectation that you're just after 3 months you're just supposed to pick up and carry on as normal, when nothing is normal. Nothing, nothing physically, nothing emotionally, nothing lifestyle wise. But in this modern culture, we're expected to pretend like nothing happened when everything happened. you know the
Yeah.
entire world, the entire basis of our identity and everything has just been fundamentally shifted. And that I think that leads to a lot of the disconnect that we feel with our bodies, because we're not given time to really honor it, and to be there for it. And that's kind of where postpartum physical therapy is such a wonderful thing, because I often catch women when they're in that wonderful little phase in their lives where they are given the chance to rest and recuperate and care for themselves during maternity leave, right, which
Right.
very for a lot of people, but for a lot of women, it's really the first time they've gotten to do any self-care. So, when I'm seeing somebody in clinic 6 weeks postpartum, or maybe even sooner than that, oftentimes, it's the first time that women have gotten to do anything for themselves. And many women feel very guilty about even taking that hour away from the baby to work on their own rehabilitation process. And you really have to reassure women that, your baby, your family deserves to have you in a healthy state, and deserves to have you, feeling good about your body, and, feeling comfortable with your new normal. And that can be really hard for a lot of women. And so that's why I really love to meet people within this really short time frame they have between the time that they deliver and the time that they have to, just pick up and pretend like everything's normal again,
Right. We know it never is.
No, never.
Again. Yeah. So you ideally, well, and I remember when we went out to dinner, you really talked about it's even better if you can see them before.
Yeah, that's my preference. It's kind of difficult to convince people that even if they're not having a ton of issue prenatally, that it is useful to come in and get just a baseline evaluation. However, most people are having at least some sort of issue with back pain, hip pain, urinary issues, bowel issues, during pregnancy, and that's usually how people get through the door. I would love to shift the culture in prenatal care to a model where, sometime in the second trimester, when everything's well established, and people are still feeling relatively normal, whatever that means, that I can see people during that period, let people know what's going on with their bodies, acquaint them with their anatomy, with their structure, their function, and let them know, how do we prehabilitate for labor and delivery? How do we optimize this process for your body in particular? And then, when you come out on the other side, how do we get back to your specific baseline? I tell patients that nobody goes into labor and delivery with one type of pelvic floor and comes out with a completely different type. No one goes in, hypertonic and comes out hypotonic. If you were hypotonic before, you're going to be hypotonic after. If you were hypertonic before, you're going to be hypertonic after. And so it's good to know where we're starting from, because that lets that really guides the rehab process. And once my patients understand that, then most of them are very willing to get that baseline evaluation and get the continuity of care going in the prenatal period as well as the postpartum period. So it's a model that we're working on changing. I hope that becomes standard at some point.
Yeah. And what about women who are aging and are dealing with like incontinence or prolapse?
Mm-hmm.
It seems to, especially with the hormonal shifts that are happening with peri and postmenopause. I mean, I guess people should just get in as soon as they can if they're having that.
Yeah. Well, it's very interesting to meet people in that stage of their journey, because once you're postpartum, once you've had a baby, you're always postpartum, and so women say, well, my baby was born 20 years ago. It's probably too late, right? No, it's never too late. But the amazing thing about, when I meet women who are in the perimenopausal, menopausal stage in their lives, is that often they've had the issues with urinary incontinence, prolapse, pelvic pain for very long periods of time, years and years and years. And number one, we've been so conditioned in our society to just think of these problems as normal consequences of childbirth and normal consequences of aging. And so they've become so normalized that a lot of women don't even recognize leaking urine when you sneeze as a problem. That's just, that's just how it is, right? And the other thing is that women are just so resilient and can learn to live with anything. Anything. I mean, I've seen women come in with, a grade 4, bladder prolapse, meaning that the bladder tissue is actually extending out of the vaginal canal, which for many people would be very uncomfortable, but they've been living with it so long, it doesn't even bother them at all. So women are so amazing in that they can, we can learn to live with pretty much anything. The flip side of that is that you don't have to, and there is support for that. And educating the community is so important, and letting people know that they don't need to deal with those types of problems. The hormonal shifts in the perimenopausal and menopausal periods do present some unique challenges in the pelvic region. De-estrogenization is going to change the quality of the vaginal tissues themselves. They can thin, they can atrophy, and that can lead to a lot of issues with sexual dysfunction, hypoactive sexual desire, issues with dyspareunia, painful intercourse. And a lot of people just sort of give up on their intimate relationships during that period, when often it can be as simple as, finding the right lubrication, the right vaginal moisturizer, whether that be hormonal or non-hormonal. There are a lot of really great non-hormonal and even natural options out there, but so many people are so reticent to talk about these issues with their healthcare providers, and often the healthcare providers don't have good answers for them either. So many women come into my clinic having been using silicone-based lubricants for years and years and years, just KY jelly from the grocery store, because that's all they knew. And we know in those de-estrogenated tissues that are prone to tearing, that those silicone-based lubricants can be really irritating and can actually create an environment where infection can be you can become more prone to infection because they're hard to wash away and they tend to harbor bacteria. So, educating women on, what can be a very simple fix for some very uncomfortable and distressing problems. The other thing is that estrogen plays a role in muscle contractility and the actin and myosin binding in the muscle fibers. And so when you don't have estrogen, when your ovaries produce less and less estrogen over the years, that contractility in the pelvic floor muscles and in the core muscles can get less and less if we're not staying on top of it. So that's why, having a practice of healthy core work, not just doing a ton of sit-ups and crunches, but really learning how to engage the pelvic floor through the diaphragm, through the breath, and through, those deep core muscles is really, really important in that stage, so that, we don't go down that road of muscle atrophy. And there are so many changes that happen in that period, but oftentimes a big thing that we're finding there is just time. It's just time, and how well established some of these issues have become, and the compensations that come along with them. So it's fascinating.
I know we're kind of running out of time, but it's inspiring me. I'm wondering when we get out of this COVID closure, that maybe sometime we can do a workshop together.
Yes.
Talk about different ways of addressing that. And going through perimenopause myself, I've really learned about like what happens with low estrogen and different natural ways of treating that, and how to really help the elastin, if you will, in the vaginal tissues, and just being really frank about that. And I talk about that with some of my clients too. And I know that when I was seeking help for perimenopausal stuff in my early 40s, practitioners didn't want to work with me because they said, well, you're strong, you're healthy, you're blah, blah, blah. I said, yeah, but I'm like, listen to me. I was like, I have these symptoms. I want to address it. I want to be preventative, because I have that choice. I can be preventative in my own health if I want to.
Yeah.
And I'm not going to accept this as like, not something that I can't support.
Yeah. Absolutely. Well, like I said in my presentation yesterday, and if anybody remembers anything about me, I really hope it's this, is that it is never normal to leak, ever. It doesn't, and it's not, pelvic floor problems are not a natural consequence of aging. It's not like hair turning gray. These are always, it's always a sign of dysfunction, and a dysfunction that can be rehabilitated. So I really hope that people hear that and take that to heart, and I'm gonna just repeat it over and over and over until it becomes normalized. So.
Yeah. Thank you. So what if people want to get a hold of you over at Holy Cross, what's the best way for them to contact you?
So if people want to contact me directly, say people have questions about pelvic floor rehab, is their issue something that can be helped with rehab? I encourage people to send me an email directly.
Okay.
LCheek, CHEEK, at taoshospital.org, Or if you just Google Holy Cross Physical Therapy, it'll give you our phone number, 575-737-0304. You can give them a call, and our wonderful front office staff can help get us connected. I'm always really happy to answer any questions people have regarding pelvic PT, and if people need help, getting referrals or any navigating the medical side of it, I'm always really happy to help people with that too.
Awesome. And I could put that in the notes.
Yeah, that'd be great.
Yeah, I'll do that. Okay, thanks, Lisa.
Thank you so much for having me. See you soon. Stay safe out there.
Okay, thank you. You too. Looking forward to hanging out soon.
Yeah, me too. Bye.